now. And you can go ahead and start, Loretta.
Thank you for joining us today. If you have questions, please type them into the question and answer, and we will have an opportunity to discuss them at the end. Since we are recording this webinar, it will be available later on for you to view. There's a feature at the bottom of your Zoom screen that allows you to view the live transcription if you need to do that. I am Loretta Alexander, Health Policy Director at Arkansas Advocates for Children and Families. Joining me on the webinar today are Anna Strong, Executive Director of the Arkansas Chapter of the American Academy of Pediatrics, and she will speak to you more about her organization as well as how our work group will proceed as we address these Medicaid changes here in Arkansas. We also have one of our panelists is Tricia Brooks, Research Professor at Georgetown University, McCourt School of Public Policy, Center for Children and Families. Tricia has a long history of working on issues related to eligibility and enrollment policy, program administration, and the quality of health care, and she currently serves on the Medicaid and CHIP Payment and Access Commission, an independent commission that advises Congress, the states, and Centers for Medicare and Medicaid on issues affecting Medicaid and CHIP. She'll speak to us about the agency changes that were put in place at the beginning of the pandemic and what is necessary to unwind all of the public health emergency changes that are in place now. And now I will turn you over to Anna Strong, and she'll speak to you.
Hey y'all, I'm Anna Strong with the Arkansas chapter of the American Academy of Pediatrics. It's good to see a lot of familiar faces in the attendee list today. I'm excited to be here to introduce Dan Walter, who is the Senior Policy and Government Affairs Analyst with the American Academy of Pediatrics, the national organization. He works in the state advocacy department there, and he's going to speak about the impact of the public health emergency on pediatric services. Dan has really been my go-to guy on all things related to the Affordable Care Act, Medicaid, CHIP, all kinds of things that we are going to touch on the subject we're going to speak about today. And he has been at the AAP for a long time, since 2000. And previous to that, he served as a legislative analyst for the American Osteopathic Association and had some work on Capitol Hill as well. And we are very excited to tap into the expertise of both of these experts as we talk about the end of the public health emergency today. Loretta, I'll hand it back to you to talk about Arkansas Advocates.
All right. Arkansas Advocates is a nonprofit organization that advocates for children and families. Our mission is to stand up for children and families who live in or are near poverty, to have resources and opportunities to lead healthy and productive lives, to realize their full potential, to feel, do, and be their best. We are a nonpartisan, independent voice for children and families. We use our voice for children at the Arkansas State Capitol and in Washington, D.C. for legislative advocacy. We conduct research to support public policy that serves all children and families here in Arkansas, and we organize coalitions of diverse groups to drive change. Now, Anna will speak to you. Anna will speak to you now about the the Arkansas chapter of the American Academy of Pediatrics. Anna?
You got it. I tend to have roles and jobs that are a mouthful. So I'm with the Arkansas chapter of the American Academy of Pediatrics, and our mission is to attain optimal physical, mental, and social health and well-being for all children in Arkansas through advocacy, service, and professional support of our members. And so we really work to make sure that pediatricians in Arkansas are well-equipped to help support kids in all the ways that we define health, through their work and through our work at the Capitol, both here in Arkansas and at the federal level as well. Okay, so I guess I'm just going to kick us off today. This webinar is really meant to cover some of the opportunities that lie ahead of us regarding redeterminations for people who are receiving Medicaid services. We know that our colleagues at the Arkansas Department of Human Services will be able to make some decisions and changes based on both state and federal laws regarding the end of the public health emergency. And we know there is because the federal context which is mostly what we will talk about today, but additional state context may also be something that will impact how the decisions are made as well. And we'll address those state level discussions at a later time. And I'll just say, if this discussion gets you jazzed about making sure that we preserve access to healthcare and healthcare coverage for kids as operations and the world kind of returns to normal. Oh, I'm so sorry. Loretta and I will be working with our colleagues to convene a smaller work group to dig into issues and specific advocacy opportunities in the coming months. All right, well, Tricia, if you are ready, I'm going to turn it over to you to just take it off.
Gotta find that unmute button first. Thank you, Anna, and thank you, Loretta. My organization, the Georgetown Center for Children and Families, focuses on advancing access to high quality, affordable health care for children and America's low income families. And we focus mostly on Medicaid and CHIP. We work closely with Arkansas advocates in their state work, as well as the AAP at the national level in engaging pediatricians in our advocacy work. So it's a pleasure to be here and talk about some of the changes that could come about at the end of the public health emergency, particularly if the Build Back Better, which is what it's called, the Reconciliation Act, that has now been proposed in the House of Representatives of Congress, if that is enacted, some of the changes that it will bring about as we go further toward the end of this public health emergency. Rebecca, you can go on to the next slide, please. So let's start by talking about sort of the current framework. So back to almost 2 years ago, which is very hard to believe, one of the first acts of Congress after the public health emergency was declared over COVID-19, Congress implemented the Families First Coronavirus Response Act. Now, in that act was additional federal funding for state Medicaid programs, often called a bump in the FMAP or a boost in the FMAP. And that's a common strategy at the national level, particularly when states are encountering economic downturns. What was particularly different about this particular legislation and increase in federal funding is that it requires states to do more than these efforts have typically required. Those are called maintenance of effort provisions. So what goes along with the enhanced federal funding, it is a requirement for states to maintain eligibility levels and enrollment procedures. That has been standard in the 25 years I've been working in this space. What was new in this particular legislation was that it requires states to keep Medicaid enrollees continuously covered through the last day of the month when the PHE ends. Now, we don't know when the PHE is going to end. It was recently extended by the Secretary of HHS on October 18th. It's always extended for 90-day periods, so it runs now until the middle of January. This provision, by the way, does not apply to CHIP, known as ARKids B, in your state. So for the states to get this extra money, they can't change eligibility, they can't change the way they enroll people, and they keep people continuously covered. But states were encouraged to continue processing renewals and changes if it meant that they could actually extend out those annual renewal dates, at least to the extent that states have access to data to do so. Next slide, please. So as a result, of course, your enrollment has increased. Your enrollment is, a product of new people coming into the program and people leaving the program. So while new people, children and adults, have been coming into Medicaid since the public health emergency was declared in March of 2020, there haven't been people going out of the program. So as a result, you can see over this 3-year span that while your Medicaid enrollment was fairly level prior to the pandemic. There's been a substantial increase, particularly for adults. These data only go through March. These are data that your state reports to CMS. I know the state puts out different numbers as well. I think the key takeaway from this slide is the recognition that there's been a fairly significant increase in enrollment in Medicaid over the past 2 years. Next slide, please. So as this public health emergency has lingered, as things have settled in some ways, the CMS, the Centers for Medicaid and Medicare Services, which oversees the federal Medicaid program, started to put together guidance for the states and what the expectations would be for the states when they start processing normal operations. So there was guidance put out by the Trump administration in December of 2020 that has now been updated by the Biden administration last August. And at the end of this slide deck, there are some resources if you want to dig in to any of these materials. I have links for them. So the current guidance tells states that they must have a plan in place for resuming normal operations. And the revised guidance gives states a full year to return to their normal eligibility and enrollment operations. They have to catch up on any overdue applications in 4 months. If they are doing any post-enrollment verification of eligibility criteria, that has to be caught up within 4 months, but they have the full 12 months to catch up on overdue renewals or changes in circumstances. However, what's really critical here is that the state has to conduct a fresh review of eligibility before they end coverage for anyone. And in doing that, they have to look at the current circumstances of the individual. They must consider whether that individual could be eligible for other pathways in Medicaid. And that they should be prioritizing action on individuals who are most likely to be no longer eligible for coverage. Next slide, please. However, there are some major changes that have been drafted in the Build Back Better legislation. So originally, this enhanced federal matching funds of 6.2 percentage points was expected to run until the end of the quarter in which the public health emergency ends. So at this point in time, that would be March 31st of 2022. And that 6.2 percentage point increase in federal funding will remain in place until the end of the first quarter next year. However, beginning in the second quarter, April to July of 2022, that enhanced match will be reduced to 3 percentage points, and it'll be further reduced in the third quarter between August and September to 1.5%. And along with that, of course, comes some changes in that maintenance of effort provision. It allows states to restart renewals and processing changes starting next April. However, it does reinforce the requirement that the state has to conduct a fresh review of eligibility before disenrolling anyone, and that they must consider other categories of eligibility. So for example, a child turning 19 who becomes eligible for the adult expansion, that's how you would consider them for a different eligibility criteria. Also, in that 6-month period between April and September, the state can only act on enrollment for individuals who have been enrolled longer than 12 months. They also are making sure that states don't get overwhelmed by coming out of the gate and processing too many renewals in a given month. So they are limiting the number of renewals or redeterminations that a state can initiate in a given month to 1/12 of the total enrollment in each of those months in that 6-month period. Next slide, please. There are also some additional requirements for states, specifically regarding updating contact information and handling returned mail. Now, returned mail has been a long-standing problem in Medicaid, and keeping contact information up to date. And that's because low-income families tend to have less stable housing and move around. And there have not been strong requirements for states to take proactive steps to update contact information. But Build Back Better would indeed require the state to make a good faith effort to update contact information, including not only mailing address, but phone numbers and email addresses. I know you don't have health plans well, you have health plans in Arkansas, but not for Medicaid. The state is at least expected to check other programs like SNAP or fuel assistance, some other programs, to see if perhaps those programs have an updated contact information. It's also going to be really important to have a very strong communications campaign here, because think about it. If the public health emergency, which it did, started in March of 2020, someone that had enrolled in April of 2019 hasn't been through a renewal since April of 2019. It will be 3 years since they have had to renew their health coverage. Now, we know there've been lots of housing displacements during the public health emergency. So we know that this issue of having updated contact information is going to be huge. In the past, states actually have not had to really act on returned mail. If they got returned mail, they could actually disenroll someone because that person had not updated their contact information. But what Build Back Better does is require the state to make 2 attempts to locate the individual using 2 different methods. So you send out the notice gets returned. You try to make a phone call, or if you have an email address, you try to email the individual. But states are not going to be able to just automatically disenroll someone based on 1 piece of returned mail, which is a really important policy, and I'd love to see this become permanent. Also, states must give that individual at least a 30-day notice after that second failed attempt before the disenrollment takes effect. So these are really, really important and strong provisions that we were really happy to see in the Build Back Better draft. They also have some monthly data reporting requirements. And I'll talk first about call center statistics, because I believe this is the canary in the coal mine. When call volume goes up, call wait times go up. That is, if you haven't expanded the staffing that you have in your call centers. And when call wait times go up, abandonment rates go up. What that means is that people hang up because they've got to go back to work, or they can't stay on the phone for 2 hours. They've got limited minutes on their cell phone. So when we start to see these numbers going up, it is a signal that we need to slow down, because people are not necessarily getting the help that they need if they have to take action to stay enrolled. Also, the data reporting requirements are going to include the state reporting how many redeterminations it processed, and of those, how many people were disenrolled. And of the people who were disenrolled, how many were disenrolled for red tape or administrative barriers? They didn't get their mail. They weren't able to get the documents needed to verify their eligibility. We call that procedural reasons, because we know that historically, I don't know, some 25 to 30% of Medicaid enrollees who are disenrolled for procedural reasons, we don't know whether they were eligible or not, actually had ongoing eligibility. And that creates churn. People fall off the program, they don't know it, they show up at their community health center or their pediatrician's office, they say, I have Medicaid, or my child has Medicaid, and the provider says, no, your Medicaid ended 6 weeks ago. So they end up reapplying, and that's something that we call churn, and that's been an ongoing problem in Medicaid for many years. Additionally, the state has to report how many people are transferred to the marketplace if they are no longer eligible for Medicaid. And this is another area where understanding procedural disenrollment is important, because if a person is determined ineligible for Medicaid, they are transferred to the marketplace. And we believe that the federal marketplace is actually going to implement a new strategy where they do direct outreach to people whose accounts, electronic accounts or information is transferred to the marketplace. But if someone is disenrolled for a procedural reason, their account is not going to be transferred. It's only going to be transferred if they were determined ineligible. So it's going to be really important for us to get the word out that people should respond to any request for information with their state, even if they think the state has gotten it right, that they are no longer eligible. If they respond and the state can confirm that they're no longer eligible, then they would get transferred to the marketplace. So monitoring these numbers are going to be really important for us to, again, make sure that everyone who remains eligible for Medicaid stays enrolled in Medicaid. Next slide, please. This is just a slide that shows the difference between the two dates that, based on the current legislation, that the PHE would end in January. That means the continuous eligibility provision would end at the end of January, and the 6.2 percentage point bump in federal funding would go till the end of the quarter. But if Build Back Better passes, then that all changes, with April 1 being the end of the continuous eligibility provision, and as I stated earlier, the FMAP phasing down. Next slide, please. And by the way, the Biden administration could extend the public health emergency, but if Build Back Better passes, then it basically delinks this from the end of the public health emergency. So we are expecting more guidance to come from CMS. Before we saw a draft of the Build Back Better, there was additional guidance in the works. It was intended to address a lot of questions that the states had been asking the CMS. It was going to provide more details about updating mailing addresses and return and dealing with returned mail, about reporting performance indicators and key data. And we were told a couple of weeks ago not to expect that for a few weeks, but I would anticipate that that guidance is now going to be delayed, because I don't think CMS wants to come out with two sets of guidance about the end of the public health emergency. So the BBB, of course, is going to change the guidance in terms of how this enhanced federal match works, what those special enrollment rules say about updating contact information, return and dealing with returned mail, and some other changes, which I have a bonus slide at the end to talk about my favorite provisions in Build Back Better when we get to that point. Next slide, please. So I want to start by talking a little bit about what states can do, and then I'm going to turn to what advocates can do. And as I talk about what advocates can do, I recognize that not everyone is in the weeds the way that at least some of us on this phone call or on the speaker list here are. So I want to talk about things that you can do at a higher level, and if you want to dig deeper, and then if you want to think about permanent changes to improve your programs for kids and families, I've got some thoughts about that as well. So what can states do right now to get ready? So first of all, states should be doing their best to renew as many people as they possibly can, even though they can't disenroll anyone. So states have access to a lot of data. I don't know exactly all of the data sources that your state uses. I do know that Arkansas reports a fairly high level of what we call ex parte renewals. That's renewals that are based on third-party information. So you can use quarterly wage data, you can use a SNAP recertification. All of that information can be used to actually renew Medicaid without asking the individual to fill out and return a renewal form. States should be getting the word out to beneficiaries. It's been a while since we've chatted with you, since we've communicated with you. If you've moved, please update your contact information and giving them easy ways to do that. You could dedicate, an entry on an automated voice activated system that says, if you need to update your address, press 2 now. And it gets you to people who are going to actually take that address change so that you're not waiting on hold for an hour while people are dealing with more complex issues. Also expanding the modes of communications. And I'll talk about this a little bit more when I talk about some permanent changes that Arkansas could make. One of the things, unless you've deployed it since January of 2020, you do not have online accounts for individuals to help manage their Medicaid information. And that is a key way that states can do electronic communications with people. And people tend to keep their cell numbers or their email addresses longer than they do. Now, I know that internet access and use of computers may be lower in Arkansas than in some states, but certainly we know that the younger generation, those that are parents of young kids, are coming up in a world where access to digital technologies is more prevalent. And then, as I've mentioned several times, communicating with beneficiaries and stakeholders. The communication should probably come in phases. We don't want to throw everything at people at one time. We don't want to send them a 4-page notice that says, oh, update your address. And by the way, we're going to start renewals at some point in the future. And oh, by the way, we're also reactivating prior authorization for certain services. So whatever those changes may be, communicating those in phases will be really important. So starting with what people need to do first, which is update their contact information. How will we know, is the state ready? Well, we want to make sure that they are balancing their eligibility worker and call center capacity and staffing with the size of their backlog. So if the state's done a pretty good job of continuing to renew people, the backlog will be smaller and they can manage it with a smaller workload. The other way to manage the workload is to take the full 12 months. To actually get back to your normal operations. Making sure that eligibility workers are trained and understand what's happening. Providers, navigators, community health centers, hospitals, key stakeholders all need to understand how the state is planning to approach this, because they're going to be getting questions from their constituents along the way. Making sure that enrollees are aware of those upcoming changes. And then making sure that if the Build Back Better Act is passed, that those new provisions for returned mail and updating contact information have been put into place. Next slide, please. So at a high level, advocates really want to understand what the state's plan is. I think we need to go to the next slide, please. Maybe a little glitch there. We really are encouraging states to be transparent in their planning process and to engage with stakeholders. I'm assuming we're not frozen here because I can see myself moving. Okay, Rebecca, we're having problems with the slides. We may have lost Rebecca. Okay, I am going to keep going here. We want advocates to engage with their states. Ask your state what they're planning to do, how they're planning to approach the phasing out of the continuous eligibility provision. And to really have a give and take with stakeholders, because when we put more heads together to talk about what's the best way to approach this, we're going to come out with better solutions. And we should all share the goal that every eligible child, every eligible parent, every eligible individual should be given the opportunity to retain their Medicaid coverage. We also,
I don't know.
Hey, Rebecca, you're not muted right now.
there we go. I think we got a new slide. So I think we're good to go. I think the best way for states to approach this is to take the full 12 months to return to routine operations. But again, if the state's done a good job and doesn't have a large backlog, maybe they can do that in faster time. I think it just is trying to find a balance there, pushing for that robust communication strategy, and ensuring that key stakeholders clearly are aware of what's happening and are ready to help, be they Medicaid providers, your key legislative champions, your Medicaid advisory committee, any community-based organization that deals with families that are on Medicaid. These are all things that you can do at a very high level. But next slide, please. If you want to go deeper, then I would really be pushing your state to make their plan transparent. So there's no requirement. There is, as I said in the beginning, there's a requirement for the state to have a written plan, but there's no requirement for the state to submit that to CMS for review or approval. CMS does have the authority to request that plan if indeed they have reason to believe that things are not going well. And the best thing that we can do, because we all talk about accountability and transparency, is to be transparent in this process. Encourage your state to post their unwinding plan, to post the enrollment data that I mentioned earlier that they are supposed to submit to CMS. And to really get under the hood a little bit about when action is required to maintain coverage, encouraging the state to contact enrollees more than once. Now, we talked about this for returned mail, but if the state sends a request for information, they contact enrollees once, and if the person doesn't respond, they can disenroll them for procedural reasons. But sometimes you need to work a little harder at it, and using those different modes. And in Arkansas, maybe phone is going to be the best one for that. Advocates should also feel free to supplement communications to providers and navigators and consumers. At the end of the slide deck, I have a link to some communications toolkit that you are welcome to use to your heart's desire to do this. Monitoring the data and the impact on real people, working with your providers and your navigators to gather up those stories and assess trends and to detect real problems in the system, and work with health reporters to lift up the lived experiences of enrollees. If you remember when Arkansas implemented work requirements, you know what happened then. A lot of people lost coverage. Even a lot of kids, even though work requirements didn't apply to them. And a lot of it was because that they were confused, and it really took all hands on deck to address the issue. Next slide, please. So a couple of things for folks who want to see permanent changes. As I mentioned, Arkansas does not have online accounts unless it's deployed something in the past year or so. Also, you do not report having a mobile-friendly application or a mobile app. These are ways to increase access. A number of states have portals where navigators and assisters can help submit an application on behalf of individuals. Making sure that there's ongoing outreach at the community level. Implementing a certified application counselor program. Using SNAP recertification to extend out Medicaid. Enrolling kids in or renewing kids using a process called express lane eligibility, and also implementing a full year guaranteed coverage in Medicaid. Your kids in CHIP have it right now in ARKids B, but not in ARKids A. And I honestly don't understand why we treat our lower income children any less well than we treat our moderate income families. So this is a really key point. And I think we've missed that slide. And gosh, I can't even show you my bonus slide, which has a big red heart on it. You'll have to come back and look at the slides later. But two things in Build Back Better. One is that back about a year, not even a year ago, the American Rescue Plan gave states a new state option to extend postpartum coverage following pregnancy, which is now limited to 60 days, up to a full year. Build Back Better goes one step further and requires states to provide full year coverage for after a pregnancy. This is going to be so important to maternal health and a mother's ability to nurture her child and bond with that child. The other thing is that Build Back Better will require the state to offer full year coverage for children in both Medicaid and CHIP. So these are really critical and important advances in maternal and child health with Build Back Better. But we also will want to make sure that there's a smooth transition as we phase out this continuous coverage provision under the public health emergency and move to implement those. So my last two slides are just resources that I hope you can access later. I have developed a toolkit that's called Tips for Advocates that dive a little more deeply into some of the things I've touched on today. There's that communications toolkit on updating your mailing addresses. And then there are links to the CMS guidance and additional resources, as well as my contact information. So with that, I am going to stop there. I hope I didn't go too far over my time. I know we're a little late getting started, and I will turn it back or maybe straight to Dan, Anna or Loretta.
I think that works to go ahead and hand it straight to Dan. Would it be better if Dan shared his own slides? Would that be easier?
I can certainly do that, or at least
I'll
try to
check.
do that.
I'll check.
I don't know if you can while Advocates is sharing, but you might, unless you can, you could try.
Oh, you know what? It says it's disabled. I'm sorry. I guess I can't.
Give it 1 sec. Maybe you can in just a second.
Okay.
Yeah, the host has to give you sharing rights.
Oh, okay. Says it's still disabled.
Let me see if I could pull. Oh, no, this is disabled on my end too. Hold tight, everybody.
Sorry about that, Rebecca's. Everything is frozen with the cloud technology. So we will.
Laura said she's logging out and logging back in. The
Oh,
solution
okay.
to all technical problems, hopefully.
Yeah. And while we're waiting for Rebecca to log back in, I'll just certainly issue a great round of applause to Tricia for all of that complex information she just shared with us. And Tricia, I promise you, we will make sure that people see your bow. As I said during the introduction, Tricia is a national expert on eligibility and enrollment, and she has just brought us a wealth of information regarding how we're going to have to go forward with the eligibility and enrollment process for unwinding the public health emergency, and even more as in today's climate, what's going on as we speak in Washington, D.C. So we also have some of our board members that are on today, and we want to thank them for being here. Again, Anna we brought the pediatricians in. So, you know, we're just starting this process, y'all. We're gonna have a lot of work groups. We're gonna have a lot of meetings. So, because our ultimate goal is to make sure that everybody stays on Medicaid that is eligible. And we want to just really go forward with that. So now,
And it looks like you might be able to share now.
I think I can
Yeah.
share my screen. Yeah. Okay.
yeah,
Can you guys see this?
All right.
Yes.
Yes, we can. It's still not in presentation mode yet, but give
Yeah,
that a
let me-
try.
Yeah. Great.
There you go.
there you go.
The wonders of technology. Hi, everyone.
Buddy.
Thank you so much. Thank you so much for the opportunity to be here. I want to thank Anna and Loretta, and I'm just really glad to participate in this. You all do great work in Arkansas. When Anna approached me about this webinar, I said, if we're going to talk about redeterminations, if you wanted me to talk about redeterminations, I would be literally stealing from Tricia Brooks. So I'm glad that I didn't have to do that, and that she's here to give us all the wisdom as to how this is or should go. I guess I'm here to color in sort of the background on this issue and to talk about what's been going on in kids' health, child health during the public health emergency. And I'll show some data, but when we talk about the redetermination process, I think we think about it first and foremost as an administrative task, a Herculean administrative task, and I certainly applaud any state official who is tasked with making this a reality, because certainly it's going to be an enormous lift. But from our perspective, the AAP, this is coming at a time, when we think about what's been happening to children's health and during the pandemic, and one could argue that these redeterminations are happening, whether or not the Build Back Better delinks from the end of the public health emergency, or it continues on the path that it's at least currently on, and it's a time when children really need care the most. So let me see if I can move my own slides. And there we go. Okay, so where are we in terms of the pandemic and children? These are data that the AAP and the Children's Hospital Association collect. I hope you can see these okay. These are through just last week, child cases added in the last week across the country. And thankfully, the numbers are declining greatly. But when you look at sort of where we're at, we're kind of where we were at in January, which was not necessarily a great place. And this just shows that transmission is still high among children. Delta is very transmissible. Kids are still getting COVID and transmitting it to others. This next slide shows the percent of children cases reported in the last week and the cumulative percent of children over time. And what we've seen is that this is certainly increasing, that children are a greater percentage of COVID cases than they were a year ago. And that is simply because more people are getting Delta and transmitting it. And that's true of children too. Here we have the state-specific data. You can see that a little over 89,000 children in Arkansas have contracted COVID, about 17% of cases in the state. And of course, this, we think about the children who have COVID or who have had COVID and had morbidity and mortality related to COVID, but there are a lot of other ways that children have been affected by this pandemic. This here is our president, Dr. Lee Beers, testifying before Congress a little over a month ago on the needs of children during the pandemic. And I don't think it's overstating it to say right now that those needs are many. And when we think about the redetermination process, we have to think about all of those needs and sort of making sure that we think about kids first and foremost in mind. Just to tick off a few, you probably read last week that the Academy, together with the American Academy of Child and Adolescent Psychiatry and Children's Hospital Association, declared a national emergency for children's mental health. Certainly, mental health issues among children have been on the rise for a full decade, but there's been there's been dramatic increases. And just to give you a few statistics, between March and October of 2020, emergency department visits for mental health emergencies rose 24% for children ages 5 to 11 years old, and 31% for children ages 12 to 17. Emergency visits for suicide attempts increased nearly 51% among girls aged 12 to 17 in 2021 compared to the same period in 2019. Vulnerable populations are absolutely more at risk, but children have also lost parents and caregivers. 140,000 children have lost a primary or secondary caregiver during the pandemic, with children of color being disproportionately impacted. At our recent NCE, our annual meeting, researchers showed there's been an increase in child abuse, increase in child injury. CDC data shows a rise in childhood obesity during the pandemic. Pediatricians are anecdotally reporting a rise in eating disorders. And we all know also the effect on education. My daughter is in second grade now. My oldest daughter is in second grade, and they're wearing coats in school because they keep the windows open. I don't know how they're learning, but they're doing it. But she's never, this is her entire kindergarten. This is the third school year of this pandemic, as I'm sure many parents here can relate. But this really speaks to the need for us to get this redetermination process right. In healthcare, there's the concept of the warm handoff, and I think that applies here. Really thinking through how do we think about this in a way to maximize making sure that kids don't lose coverage as these redeterminations get made. A little bit more data. So these are from the Commonwealth Fund. These are the percent changes in outpatient visits by baseline, or from baseline by specialty. The chart on the left is the last 3 weeks of 2020. You can see that pediatrics is down 24% over baseline. The chart on the right is the cumulative effect through the same period, so the end of last year. Unfortunately, we don't have more recent data, but whether it's first or last place, pediatrics has certainly seen the brunt of children not coming in, families not coming in, for very reasons related to wanting to protect their kids. And even though pediatricians and others have done an enormously great job of making their practices safe and adapting and using telehealth and having vaccine clinics and parking lots and all kinds of things. This was the impact last year. And while we know that it's getting better, and certainly anecdotally we're hearing that people are coming back into the offices, this has had an effect. Here we can see the decline in vaccine for children orders through August 16th of this year. And the green is all non-flu doses, the blue is measles containing doses. But what this shows is that basically kids have not been vaccinated. We're not talking about COVID-19 vaccine here. We're talking about the routine childhood vaccinations that protect against so many important diseases. Through September, CDC's data shows that we're down 13.2 million doses. My understanding from talking to Anna is that you all are doing pretty well in Arkansas and bringing those numbers back, and that's great. We want to hear that. The Academy is doing all it can to promote vaccine confidence, both with COVID-19 and with other vaccines, other routine childhood vaccines. But this work will continue. This is just a Call Your Pediatrician campaign that we've undertaken at the Academy. Tried to use some humor. This is a mom turning into a superhero as she gets her childhood vaccinated. We had a video of a panda that was very popular. Pandas getting panda checks, I guess, are pandas are cute. I agree. But it's a concerted effort on the part of the Academy to get kids back to care and to make sure that they're up to date on all their vaccines. So when we think about redeterminations, the Academy has a long-standing support, unflinching, unwavering for Medicaid and CHIP. There are obviously issues with these programs that need to be improved, but our advocacy, I know your all advocacy there in Arkansas has covered the waterfront, so making sure that harmful proposals aren't implemented, work requirements, block grants, others, access to care is improved, enrollment is streamlined, EPSDT is maximized. We want to see Medicaid work because Medicaid works for kids. I don't need to read through all this, but certainly research continues to demonstrate the positive impact that childhood Medicaid coverage has on all these different factors. The study on the right was one that came out last year. The Federal Reserve economist out of Minneapolis, Andrew Goodman-Bacon, did a cost-benefit analysis of childhood insurance coverage through Medicaid using the natural experiment of Medicaid when it first came online after the program was enacted, and found that a lot of these short-term impacts on the left are true, but also that many adult impacts exist, such as reductions in later life mortality, lower rates of adult disability because you had childhood max Medicaid coverage, higher rates of employment later in life, and even found that when you take all those benefits and costs and put them together, as economists can, that the program not only pays for itself, but it saves money because you aren't spending money in those other programs through the benefit that Medicaid has achieved. This slide is from the AMA's economic impact study, and it specifically shows the impact of physician practices in Arkansas. Don't need to read through it all, but just to say that, you know, when the pandemic hit, we certainly saw practices, as was shown on the other slide, the reduced volume of patients coming in and practices having to pivot quickly and do things to stay afloat. Not to say that that's going to happen here with this redetermination process, but to think about, you know, the impact on practices as well as the source of care, particularly in rural areas where they may rely on, you know, a larger Medicaid panel to ensure that whatever happens with redeterminations, you know, these impacts are notable. I'm stealing from Tricia explicitly here. The importance of continuity of coverage. It improves health status. It helps address equity issues. It mitigates income volatility, particularly of families on Medicaid who might see, you know, more work this week, less work the next month, or whatever it is that could change that income. It drives efficient healthcare spending, so we're not spending it treating a sicker condition later. We're keeping the kid covered and getting the condition treated over the course. It reduces administrative costs. You know, churning is costly, and certainly there will be expenses there. And it enhances the ability to measure quality. If we're going to look at how the healthcare system is working, you have to have those kids enrolled for longer periods of time. I'll just lift up a couple of the points that Tricia made and say that, you know, from the Academy's perspective, we're certainly here to help however we can. I think the points about monitoring and transparency are paramount. You know, the more sunshine, the more we know exactly how things are being done, the more that's being communicated, I think will be helpful. The Medical Care Advisory Committee could be an avenue. That's something every state Medicaid program is required to have to sort of surface some of those issues that happen, as certainly there will be as redeterminations take place. You know, something we're having right now with the rollout of the COVID-19 vaccine for kids 5 to 11, just thinking through how can we get this message out 8 ways, 8 times, or maybe it's 64 ways, 64 times, given just the current environment. But how can practices help families understand the coming changes? And that's probably incumbent on us at the Academy to help our members help their families think through, you know, these changes are coming and what can you do? And I think a lot of what Tricia mentioned is absolutely correct in that regard. Elevate the effect on practices, tell the child and family stories, and then finally find champions to fix problems that will inevitably come up. So I guess I will stop there and just say that you know, as you all go through this Herculean task, we appreciate that you're keeping the kids foremost in mind, and we're here at the AAP National to help however we can. So thank you.
Dan, thank you so much. I know that our pediatricians across Arkansas are so grateful for Medicaid, for providing the access to care that's so important for kids. And so we know you guys are such great advocates and help us at the state level to be effective advocates as well. And thanks to those who are jumping in on the chat. I'm glad to hear from folks sharing some good blogs and other links if you guys want to learn a little more. I don't know, were there any wrap-up slides that you guys had at Arkansas Advocates?
No, I just had a wrap-up comment or two.
Okay. Maybe we can, Dan, if you want to pull down, did you end up sharing the slides, Dan? No, there we go.
Oh, again, thank you all for joining us today. I put some of Tricia's resources into the chat because we couldn't get to her last slides, but we will have a full recording of the webinar today as we go forward. And again, contact AACF and the Academy of Pediatrics here in Arkansas, and we will get you this information. we are just starting these work groups, and we will be going forward, and certainly anybody that needs to contact us, please do. And once again, Trish, we so thank you for helping us, and you, Dan, for talking about the kids. The kids are the cog in our wheel in terms of what we do. That's
The
what
reason we did this work.
yeah. All right. And that's all I have, Anna, unless you want to have final comments.
No, I think that we'll be in touch about next steps in terms of you all getting to be part of the future work. So we would love to have a broad group of folks at the table to help make sure that we are advocating for and working with our partners at the state and other organizations to keep kids enrolled in coverage and keep them connected to the care that they need over the coming months.
Thank you, everyone.